Hello to everyone from World Health Organization, our headquarters here in Geneva. My name is Tariq, and I welcome you to this special press conference following the first here in Geneva. My name is Tariq, and I welcome you to this special press conference following the first meeting of the emergency committee convened by WHO Director General under international health regulations regarding the upsurge of Mpox in 2024. We are happy to have a number of experts here in the room, a number of speakers also online, and I will just introduce some of them. With us is, as always, Dr. Tedros Adhanom Ghebreyesus, WHO Director General. We also have Dr. Maria van Kerkhove, who is Director at Interim Epidemic and Pandemic Preparedness and Prevention. With us is also Dr. Rogerio Gaspar, who is the Director of Regulation and Pre-Qualification. We have a number of speakers online. I will really would like just to welcome Professor Dimi Ogoina, who is Chair of the Emergency Committee and who is infectious disease physician and Professor of Medicine and Infectious Diseases at Niger Delta University and Niger Delta University Teaching Hospital in Bayelsa in Nigeria, and we will hear from him a bit later. Before I give the floor to Dr. Tedros, for reporters online, if you would like to ask questions, please click the icon raise hand and you will be put in the queue. With this, I give the floor to Dr. Tedros for his opening remarks.
Thank you, Tariq. Good morning, good afternoon, and good evening. Mpox has been reported in the Democratic Republic of the Congo for more than a decade, and the number of cases reported each year has increased steadily over that period. Last year, reported cases increased significantly, and already the number of cases reported so far this year has exceeded last year's total, with more than 14,000 cases and 524 deaths. As many of you who tune into our regular press conferences know, WHO has been working on the Mpox outbreak in Africa and raising the alarm that this is something that should concern us all. Last week, I announced that I was convening an emergency committee under the international health regulations to evaluate the upsurge of Mpox in the Democratic Republic of the Congo and other countries in Africa. Today, the emergency committee met and advised me that, in its view, the situation constitutes a public health emergency of international concern. I have accepted that advice. The detection and rapid spread of a new clade of Mpox in eastern DRC, its detection in neighboring countries that had not previously reported Mpox, and the potential for further spread within Africa and beyond is very worrying. In addition to other outbreaks of other clades of Mpox in other parts of Africa, it's clear that a coordinated international response is essential to stop these outbreaks and save lives. A public health emergency of international concern is the highest level of alarm under international health law. The emergency committee's advice to me and that of the African CDC Centers for Disease Control and Prevention, which yesterday declared a public health emergency of regional security, are aligned. WHO is on the ground working with the affected countries and others at risk through our country and regional offices, as well as with partners including the Africa CDC, NGOs, civil society, and more. For example, We're providing machines to analyze blood samples and confirm cases of Mpox. We're supporting laboratories to sequence viral samples. We're on the ground supporting case investigation and contact tracing, risk communication, and community engagement. We're training health workers and supporting clinicians to provide appropriate care. We're supporting countries to access vaccines and develop the strategies to roll them out, and much more. To fund this work, WHO has developed a regional response plan requiring an initial $15 million. We have released about $1.5 million from the WHO Contingency Fund for emergencies, and we plan to release more in the coming days. We're also appealing to donors to fund the rest of the response plan. WHO is committed in the days and weeks ahead to coordinate the global response, working closely with each of the affected countries and leveraging our on-the-ground presence to prevent transmission, treat those infected, and save lives. I thank the Emergency Committee for its work and advice. And I would like to give the floor to Professor Demi Ogoina, the chair of the Emergency Committee, to summarize the committee's considerations. Professor Ogoina, you have the floor.
Thank you very much, DG. Let me say good afternoon, good morning, and good evening to everybody. The DG has given an overview of the constitution of a committee, the Emergency Committee on Upsurge of Mpox 2024, and we had 16 members that constituted as members of that committee, and the meeting held today, 14th of August, this evening, a few hours ago, and 15 of the membership were in attendance. Essentially, our assignment was to determine whether the event, which is the upsurge of Mpox in parts of Africa, constitutes a public health emergency of international concern. And we are required to base our decisions on the IHR criteria for declaring a public health emergency of international concern. So members of the committee listened to presentations from the WHO Secretariat on the global Mpox outbreak, risk assessment, and current challenges, activities that are taken by the WHO and including the WHO Afro region. Members of the committee also listened to presentations from most affected state parties, including the DRC, Rwanda, Burundi, South Africa, Kenya, and Uganda. Following this, members had a deliberative session where we looked at the three major criteria, which one, whether the current upsurge of Mpox in parts of Africa is an extraordinary event. And in the view of all members, it was unanimous that the current outbreak of Mpox, upsurge of Mpox, is an extraordinary event in view of the fact that we're having the highest number of cases ever reported in the DRC, for instance, since the outbreak was reported in the 1970s, especially 2024, a very significant upsurge in the number of cases. The fact that children, the vulnerable children, pregnant women are also impacted, and a number of mortalities have been reported. Secondly, the emergence of a completely new strain of clade 1. Clade 1 is historically known to be more severe in clinical presentation and perhaps more transmissible than clade 2. And now there is an emergence of a new strain that is widely referred to as clade 1B. And what is also observed is that 1B is sexually transmitted. Also remarkable, making making it an extraordinary event is that this clade is now circulating in parts of East Africa, Eastern Africa, up to about 4 countries. It was also remarkable to note that there's a resurgence of Mpox in South Africa. About 24 cases have been reported this year alone. And amongst those cases, we have 3 mortalities. It is affecting especially people living with HIV and those with advanced HIV disease. We also looked at the second criteria for declaring a public health emergency of international concern, and that relates to whether it has a public health risk of international spread. Evidently, the fact that the new clade that is sexually transmissible has spread to other African countries, and before now, these African countries have never reported a single case of Mpox, including Uganda, Rwanda, Burundi, Kenya, reporting new cases of Mpox, and the outbreak in Burundi, for instance, is very concerning because of the geographical dispersion of a number of cases reported there. So we believe that it's already a risk for international spread, and of course, there is also the chance that it could spread beyond Africa to other regions of the world. The third is whether it requires an international coordinated response. Evidently, what we have now, this challenge of upsurge of Mpox, requires a coordinated response, not only in Africa, but globally, so that collectively all parties involved can work to improve surveillance, diagnosis, and other public health responses that are needed to nip this challenge in the bud. So having done that, we made a recommendation, and all 15 members in attendance were fully in support of all elements of the criteria needed for declaration of a public health emergency. The second assignment was to advise on proposed temporal recommendations, and those recommendations will be made available in the following days by the WHO. But just to emphasize 3 points. One is that there is need for improved investment in understanding the natural history and the knowledge gaps that are peculiar to, especially to Africa, regarding Mpox. Ultimately, addressing these knowledge gaps and improving understanding will help to devise preventive strategies, public health response, and the use of medical countermeasures such as vaccines and therapeutics and the likes. Also very important is the development of targeted interventions, prioritized targeted interventions that will address the problem according to the context in which the problems are being faced in specific African countries that are most impacted. At the background of all these recommendations is a continuation of the standing recommendations that, of course, we know that Mpox is still ongoing in many other parts of the globe, and that there's a need for concerted effort by all stakeholders, not only in Africa, but everywhere else. So in summary, those were the lines of thinking of the emergency committee and the basis of our recommendation to the DG, and that this should be considered for declaration as a public health emergency of international concern. Having said this, I would like to, on behalf of the committee, appreciate the DG and the WHO for inviting us and nominating us to serve to undertake these assignments. Back to you.
Thank you very much, Dr. Tedros, and many thanks to you, Professor Ogoina. It was a long day for you. We will now open the floor to questions from journalists, and we will start with Helen Branswell from STAT. Helen, please go ahead.
Thank you very much. I want to know about the thinking of the emergency committee on use of vaccine to try to bring these outbreaks under control. global supplies are limited, and one reads that it's estimated that 10 million doses may be needed and only 200,000 may be available. How is it going to be determined how vaccine will be distributed? Who will be in top priority? Which countries will get it? Who's going to decide that? Thank you.
Thank you very much, Helen. Maybe we can start with Professor Orgoina, and then we will see if we can have someone else to add. Professor, please.
Yeah, thank you very much for that question. So I think the issues of medical countermeasures, including vaccines, was extensively discussed by members of the emergency committee, and it was highlighted at that meeting that there are still gaps in access to vaccines, especially in many parts of Africa. And even when resources are available, in some situations, perhaps the global supply of vaccines may not be sufficient to address the needs of Africa. So this is an ongoing problem, but what is important is that all parties that made a representation at that meeting have recognized the importance of the elements, a concurrent element of vaccine in addition to surveillance, because it's very important that you understand your outbreak for you to ultimately decide what group of persons to vaccinate. And we have that gap in parts of Africa where we don't fully understand the transmission dynamics and the risk factors for Mpox that is expected to guide who we're expected to vaccinate. And so all countries and state parties, I think all the countries that presented had a costed plan, and some of those countries also had plans to ensure that they make a procurement of vaccines. And I believe the WHO is also working with countries and also working with manufacturers to see that they ramp up the production of additional vaccines that would address this challenge. Ultimately, in terms of regulatory approval for vaccines, countries like Nigeria and the DRC are already at advanced phase in terms of getting regulatory approval for use of vaccines. And I believe there are some donations that have been given, for instance, to Nigeria, and I believe also to DRC. And most of these countries already have some plans in distributing vaccines. But the challenge is that these vaccines are not sufficient, even if we need to use our theoretical knowledge to categorize the risk groups, including children, people with immunosuppression, pregnant women, healthcare workers, and the likes. Let me revert back to WHO. Thank you.
Thank you so much, Professor. Let's go maybe to Dr. Tim Nguyen, who is online, and he is from WHO department dealing with high-impact events preparedness. Tim, could you please come in?
Well, thank you, Tarek, and Helen, thank you for your question. I'm happy to give some information about our latest understanding about availability and accessibility of some of these vaccines. We're concretely talking here about two types of vaccines that have been used in the last 2 years by some member states in response to the control of Mpox, which is the MVA-BN vaccine and the LC16 vaccine. So we have been in contact recently with manufacturers this week to have understanding of the availability at the moment. So when it comes to the MVA-BN vaccine, currently about 500,000 doses are in stock at the moment that can be procured by countries or other entities. Another 2.4 million could be produced by the end of this year if buyers are there to make a firm procurement request. And for 2025, there could be another 10 million doses produced, but there needs to be a firm request for those manufacturers to plan for the production of these vaccines. So that's what is our understanding around the MVA-BN vaccine at the moment. At the same time, we work with our partners through the so-called IMCM-NET partnership, specifically here with Gavi the Vaccine Alliance, and UNICEF to work on a donation scheme for those countries that have stockpiles, that have reserves of the vaccine, and best to donate them to recipient countries that are in need. We're building these donation scheme for the purpose of understanding where to best use them when resources are scarce, and where we can use this limited accessibility of donated vaccine to have the biggest public health impact around this. When it comes to the LC16 vaccine, this is a very special vaccine in terms of that this vaccine is not commercialized, but at the moment produced on behalf of the government of Japan. In previous incidences, the government of Japan was very generous when being asked to donate vaccine to countries. And this is also one way for WHO to work with countries and with the government of Japan to facilitate donation of the LC16 vaccine, which has a considerable size in their stockpile at the moment. I stop here. Thank you.
Thank you so much, Dr. Nguyen. Dr. Van Kerkhove?
Yeah, very brief, because I know there's a lot of questions. I just want to emphasize two important points that were made. One is that we need a much better understanding of the epidemiology in the affected countries and the at-risk countries. We need to understand the transmission patterns. We need to understand the populations that are risked. And it's dynamic. There are multiple outbreaks that are happening. There are changes in terms of what we're seeing in the epidemiology itself. To understand that better will help us to use the limited numbers of vaccines that we have in a targeted and a most appropriate way. So I want to stress that one point. And secondly, to request, if there are countries that have vaccines to donate, to come forward and to work with us through the IMC-Net partnership that Tim has just mentioned. We need to have a good visibility on what is available and how those could potentially use, and of course support the countries with protocols and making sure that as part of the response, vaccines are used. Last point is that vaccines are one intervention that can be utilized, but we do know that there's such strong country work, community work in terms of risk communication, community engagement for prevention activities. And we have seen with the global outbreak, though it was due to clade 2, and here we're really talking about clade 1b. There are a lot of interventions that could be utilized in country, in communities to prevent transmission.
Thank you, Dr. Van Kerkhove. Indeed, we have many questions lined up, so let's try to take some. Let's go to Bloomberg. We have Janice Q. Janice, please unmute yourself.
Hi, thanks very much. Two quick ones. Could you maybe explain what happens next now that it's an official emergency? And my understanding to date is that there is no confirmation that there's an airborne element to the spread. But if you could maybe just talk to that and confirm if that is correct.
So perhaps I can start. So as Professor Ngoya said, that the emergency committee is working on drafting some temporary recommendations for the consideration of the Director General to issue. So that is something we expect to be able to release in the next day or two. The teams are working on it very hard, even as we speak, as we are sitting here. And so with those targeted temporary recommendations, there would be some advice for member states, affected member states, at-risk member states. I also want to highlight that the Director General extended the standing recommendations for Mpox for another year. He mentioned that at the press conference last week, and those are online. We could put that link in the chat. With regards to transmission, there's multiple modes of transmission that we really need to better understand. Primarily what we are seeing is the contact type transmission. We have seen sexual transmission, which is really what is concerning us. And now we have seen this virus, the different clades, and in particular clade 1b in sexual networks. And this is where we need to have targeted interventions, stronger surveillance, stronger contact tracing, stronger risk communication, community engagement with affected communities, with CSOs, with people on the ground, so that we could limit that onward spread. We've said this before. You've heard DG say this. You've heard Mike say this many times. We can stop transmission of Mpox with a concerted effort using a multiple approaches in terms of looking at how the virus is transmitting in which populations. We do see transmission among families as well. We do see zoonotic transmission in addition to that. So these are the primary ways that we are seeing this virus spread.
Thank you very much, Dr. Van Kerkhove. Let's move to the next question. We have Priti Patnaik from Geneva Health Files. Priti, please go ahead.
Hi, good evening. Thank you for taking my question. I had just two quick questions. One is on the status of the emergency use listing, if there could be an update on that. And second, my understanding is the amended IHRs will not apply to this particular emergency because they come into force only 10 months from now. If you could clarify that. And just another small question on, you winded down the declaration of a fake for Mpox for another strain last year. But do you think that could have the world sort of lost time in some sense? If you could help us understand that. Thanks.
Thanks, Priti. We have really many questions, many reporters online waiting. So let's try to really limit the number of questions per reporter. But let's try with let's go with the pre-qualification with Dr. Rogerio Gaspar, who is Director of Regulation and Pre-Qualification, and then we will see if we can answer the questions.
Okay. Thank you, Tariq. So regarding the emergency use listing, and just to remember that the emergency use listing is a temporary measure to be used in a particular situation, can be used outside of the FAQ, and that's why the Director General triggered the emergency use listing process last week, even before the meeting of the IHR. The Department of Regulation Pre-Qualification through the Pre-Qualification Unit has been in contact with both manufacturers of vaccines, but also with therapeutics and diagnostics for the last 2 years. As the emergency use listing was triggered last week, we accelerated the contacts with the companies, and I can announce that one of the companies is prepared to submit most of the documentation needed by this week, by the end of this week, and we have a critical meeting with the second manufacturer of another vaccine beginning of next week. So our work schedule right now, we are pointing for convening the technical advisory group, the expert committee that will propose the adoption of the vaccines under the emergency use listing around mid-September. And our team has already convened the experts for that technical advisory group with 3 tentative dates for the mid of September. So this is our timelines right now.
Thank you very much, Dr. Gaspar. Let's maybe go for the second question. The question was about international health regulations and the amended regulations. Let's go to Roberta Andraghetti, who is from International Health Regulations Secretariat. Roberta?
Thank you, Tariq, and thank you for the question. The amended the emergency committee today was informed that they were operating under the provisions of the IHR adopted in 2005 and entered into force in 2007. And not to worry about the amendments adopted by the 77th World Health Assembly in May. Those amendments will be entering into force 12 months from the date the DG officially notifies state parties about the amendment, and at present, as requested in the adopting resolution by member states, there is a linguistic conformity and accuracy check of the translation in the 6 different languages. Then once we have concluded that accuracy check process, then the Director General will be formally notifying state parties in the 6 official languages, and the amendment will be entering into force in 12 months from then. Over. Thank you.
Thank you very much, Roberta. Let's move on, and if it's possible, really, to have one question at a time. Catherine Fiancambo-Conga from France 24. Catherine, please go ahead.
Thank you, Tarek. Good evening to all of you. My question is related to the spread, and particularly in the other parts of the globe. As we know that countries like Uganda, Kenya, Rwanda are very touristic countries, and people are coming from abroad to visit the countries. So what is the situation for the moment, and also about the funding? I suppose that the funding is needed, highly needed, and what is the situation? Thank you.
Thank you very much, Catherine. For the first question, maybe we start with Professor Ogoina about the situation in African countries.
Yeah, thank you very much. Regarding the situation in African countries, from January to perhaps July or so, we have, let's talk about the most impacted African countries that are witnessing this upsurge. So DRC, for instance, has over 14,000 confirmed cases, and of course, this is an underestimation because a number of the cases in the DRC are not tested, and as such, it's likely that there's a significant underreporting in the DRC. Kenya has reported 1 case. Uganda has reported 2 cases. Rwanda 4 cases. Burundi has reported, I think, about 100 cases. And as I said in my earlier remarks, that the situation in Burundi is actually of concern because the cases are reported within a space of a month, and they were affected about 22 or 23 out of the 40-something districts in the country, which is actually very remarkable and suggests that there was an ongoing, unrecognized transmission, human-to-human transmission in that country even before the first case was detected. In South Africa, 24 cases, as I said earlier on, has been reported this year, and 3 of those cases have died. Those deaths were amongst people with advanced HIV disease. What is also important is that we are seeing a trend that sort of parallels the historical knowledge of the HIV pandemic, where disease is being transmitted from one country to the other through various networks, including sexual networks and even travel. So long-distance truck drivers have also been known to be exposed and also had confirmed cases moving from one country to the other. So amidst this number of cases, in some of these eastern countries, of course, Cote d'Ivoire is also reporting new cases. Is the challenge of the likely challenge of underreporting of cases, and the fact that Mpox, especially the new type of Mpox that is sexually transmitted, may present with atypical lesions, and a number of people may not present in the formal healthcare setting. So many of the members, for instance, in the emergency committee, are of the view that what we have in Africa is actually a tip of the iceberg, that we have a greater challenge. And because of weaknesses in the health system, we are not recognizing, or we don't have the full picture of this burden of Mpox. To that extent, there is need for us to strengthen the surveillance and invest more in surveillance and embed research in our surveillance efforts so that we can uncover the gaps that relates to the challenge of Mpox. Over to you.
Thank you very much. Let's just maybe go to to hear from Dr. Salam Gai, who is Regional Emergency Director in WHO African region, who can add something briefly on that. Dr. Salam, can you hear us?
Yeah, the chair has already said it. We have so far in Africa 2 countries that we have reason to believe that there is community transmission, which are DRC and Burundi. For the other countries, though, you talk about Kenya, Uganda, and recently Cote d'Ivoire, it is isolated case, and so far we do believe that there is no community transmission. It should be noted that in most African countries, over 40 of our 47 countries has a very effective, robust surveillance system that may miss some cases, but it would be very difficult that they miss a whole outbreak that is happening in the country. We are still working in order to reinforce that for all the continent, and also to make sure that there is cross-border collaboration that would allow that any time that there is inclusion of cases in another country, we will be able to detect it as soon as possible and respond. All the teams are in place and at all the countries in Africa, and we are working, and as said, it may need additional resources. Whatever we have, we are using the optimal way of them. Over.
Thanks. I'll just briefly address the funding question. I know you want to get to more questions, but just to state what the DG said, that there's a regional plan with an initial ask of 15 million. So we were going to be looking at the regional plan. We're going to be looking at this multi-country outbreak and a response, working with all of our partners to come together with a consolidated ask. So that number will increase, but right now it's an initial 15 million, and we're asking countries, we're asking funders to come forward to support that implementation.
Thank you very much. Let's go to the next question. If it's really possible to have one question per reporter. Christian Ulrich from German news agency DPA. Christian.
Thank you, Tarek. Yes, it's just one question. With the clade 2 outbreak in 2022 in many European countries, people got the impression that it's a rather mild disease, and if you take care of yourself, you will heal and it's over. What is the difference now in the outbreak now? Why are we so concerned? What is how lethal is this for people who get infected? Thank you.
Perhaps I can start with that one, and others may want to supplement. I think, we did see this global outbreak of clade 2 2022, 2023, largely brought under control with community action. And there are many people who suffered with infection from Mpox and the disease that it causes. And I can tell you for them, it wasn't considered mild. We do have some information on clade 1b, that it's more severe than clade 2. But I do want to stress here, and I think the professor mentioned this, there's a lot of uncertainty that we have. We really need detailed studies. We really need to understand not only the transmission, but we also need to understand the natural history. We need to see the disease patterns. We need standardized data collection on the patients that are infected with Mpox so that we could better understand the disease course, the severity of this, and most importantly, to make sure that not only are we focusing on prevention measures, but we're utilizing therapeutics and having therapeutic guidelines updated based on the evidence that we have. So there's a lot of work that's underway to address these unknowns, and there really needs to be a concerted effort to better understand this. We have an opportunity right now to really leverage this time and support our member states, to support the research that needs to be done to understand this. I'm not sure if others would want to comment on that.
Do you want to hear from Chair Goina?
Yeah, so, yeah. I think the comment I'll make regarding the severity of Mpox, regarding clade 2, majority of cases during the global outbreak, especially in the global north, had mild infection. And for those that had severe disease, a substantial, significant number of them had concomitant HIV or advanced HIV. They were immunosuppressed and perhaps not virologically suppressed. I think the challenge here for Africa is, as I said, is also the uncertainty. At least we know that Mpox, HIV co-infection, especially for those with advanced diseases, are associated with more severe manifestation and even deaths. And there's evidence from publications in Africa that alludes to that fact. So we're having a situation where we're having a new clade that is known or thought to be more transmissible and more serious, being circulating in all parts of Africa. We still have clade 2B in Africa. And Africa is a place where we still have a number of the population that are either not diagnosed because they are not, the routine testing for HIV is limited, or even when they are diagnosed, they are not receiving antiretroviral drugs. And when they are receiving antiretroviral drugs, they are not virologically suppressed. They are not taking sustained antiretroviral therapy. So the challenge here is that the one front of the challenge is that if we don't address this problem at this phase, we will get to a point where this virus, either the clade 2B or the 1B or 1A, can go into the HIV population, especially those that have advanced HIV and not virologically suppressed. And we have a significant number of persons that are coming up with severe disease and deaths. Also remarkable in Africa is that the number of deaths have been reported in the DRC affecting mainly children. Most of the deaths are in children. And we are getting a trend now where Mpox is transiting to heterosexual transmission from gay and bisexual men. We are seeing heterosexual transmission. And the implication of that is that it will ultimately impact on pregnant women. And so we have vulnerable groups, children and pregnant women, that will ultimately bear the brunt of this disease, and that will result to all sorts of complications and severity. So I think the idea is looking at the big picture and saying that we need to act now so that we avert the challenges that we foresee in the future. Thank you.
Thank you so much, Professor. Let's try to take one or two more questions. Rory O'Neill from Politico. Rory, could you please go ahead?
Thank you. Good evening. Yeah, I think we started to touch on it there, but I was just wondering if you could confirm that children are still being disproportionately affected. This situation report in June, I think, certainly confirmed that, but we've had a lot of cases since then. So I was wondering if you could confirm we're still seeing that pattern bear out where children under the age of 5 are being infected at a disproportionately high rate. Thank you very much.
Thank you, Rory. Professor Goina, would you like to take this one?
Yeah, so the reports presentations that we had during the emergency committee meeting emphasized that children are the worst impacted in the DRC, especially in areas where we are having historically endemic infections, and children are the worst impacted. But in the South Kivu or so, the epidemiological picture is a bit different. Most of the cases are commercial sex workers and heterosexuals and young adults that are most impacted. The findings from Burundi, from the presentation from the state parties, suggest that most of the, close to 60% of those that are impacted are less than 15 years of age. And the most affected group are those below the age of 5. About 38% of those are impacted below the age of 5. If you then go to countries like Nigeria, South Africa, most of the persons impacted are young adults between the ages of 20 to 40 years. So you will see that it's a mixed picture. But specifically in the DRC, if you're looking at the cumulative figure, you will say that children are the most impacted. Thank you.
Thank you very much. And if I may just, our reporter from France 24, Catherine, we have misunderstood her question. She was in fact asking about cases outside Africa. So if we can just maybe give a little bit of a picture of what's happening outside Africa. I don't know, Chair, if you can talk about that.
Yeah, so I think the report outside Africa, if I remember correctly, there are a few cases that have been reported outside Africa, and those cases perhaps are less than 100. I can't remember the exact figure now. I know remarks were made that is it the Eastern Mediterranean region? Again, I don't want to give the WHO will have to correct me on this, but essentially, I think the report indicated that there has been a significant decline and in a number of cases, and but cases are still being reported in the different parts of the globe. That tells us that there is some ongoing transmission. And I think in that presentation, members also observed that the WHO noted that some countries, including countries outside Africa, are also not reporting cases to the WHO and perhaps are not as proactive as they used to be during the 2022-2023 outbreak. And to that extent, it is possible that there is also an underestimation. Perhaps there's another underestimation of cases in outside Africa. I think there was also a report on the number of cases that have been reported in the literature, but also not reported to the WHO. So there's an ongoing transmission outside Africa, but not as significant as what is happening in some of the regions in Africa. I hand over to the WHO.
Thank you so much, Professor. And then maybe we can go to maybe a last question. We have Paula De Poggio from The Lancet. Paul?
Thank you very much. So my question is on closing the gap between suspected cases and confirmed cases. So what is the current approach towards improving diagnosis and testing so that we have true picture of the confirmed cases over suspected cases? That's my question. Thank you.
Thank you very much, Paul. Just checking who could, maybe Dr. Vakirko, would you like to try?
I can. I can't. I was going to ask if the chair wanted to go first, but maybe he would like to supplement, because this was discussed quite a lot among the emergency committee members, and this is something that's discussed among the WHO Secretariat with our member states, with our expert networks, to close this gap, to really understand the extent of infection. We need stronger surveillance in countries. First, to be on the lookout for Mpox. There are other concurrent outbreaks that are happening with measles, for example, chickenpox. So we need strong surveillance and good diagnostics. Our diagnostics teams are working to better understand the use of the current PCR tests, the other tests that exist that are out there, to distinguish between clade 1, clade 2. And so there's some improvement that's needed, certainly there. The other thing is, of course, access to these tests. We saw during COVID a lack of access, especially in low and middle income countries, and we're seeing that here as well. So part of the work that we are doing is not just trying to look at access to vaccines and therapeutics, but also access to diagnostics. So across the spectrum of having stronger surveillance, where we have surveillance, making sure that we have good contact tracing. So when we identify a case, we look at the exposures of others in the context so that we could prevent the onward spread, making sure that we have accurate, reliable, affordable diagnostics, and making sure that those are accessible in countries countries, working with manufacturers of diagnostics to make sure that those reach the countries in need. If there are requests for diagnostics from countries, that is something that we need to be aware of. We are aware of several, and we are looking at how we can get those those diagnostics into country.
Thank you very much. Professor, would you like to add something to this?
Just to say that it's important that, hello?
Yes, we can hear you.
I think it's, the challenge of testing is significant, especially in the DRC, where perhaps less than 30% of cases, and it has increased over time because of some investment from the FIG that was declared in 2022 and support from partners, both at national and non-governmental organization. And I'm aware that it was actually presented at the meeting that Gene Expert, for instance, has been deployed to the DRC to improve diagnosis. So members emphasize the need for us to the globe, all the health authorities to invest in improving diagnosis, especially in the DRC where cases are not being tested. And that is a significant challenge that needs to be addressed, because ultimately we are working blindly if we are not able to test all suspected cases. And that also demands research and development to develop more innovative, more cost-effective, and more accurate point-of-care diagnostics that can be deployed to rural settings. Because one of the challenges of diagnosis in the DRC, for instance, is people live in and develop Mpox in remote areas where they don't have access to the city centers where these diagnostics labs are situated. So there's a need to decentralize and look for more cost-effective point-of-care diagnostics that can be applied to improve the test rates for cases of Mpox in various parts of Africa. Thank you.
Thank you very much, Professor. And we will take one last question, and then we will be at the hour. So we go to Jennifer Rigby from Reuters. Jennifer, please go ahead.
Hi there. If you can hear me, what I wanted to ask is going back to vaccines, just if there's any timeline for when any kind of campaign could happen in Congo or the other affected countries. We've heard sort of October as a best case scenario, but I just wondered if the WHO has any guidance on that.
Thank you, Jennifer. So on the vaccination countries, maybe we can see with Dr. Salam and also Chair if they could say something about this. Dr. Salam?
Thank you very much. Actually, given the amount of vaccine that are available in Africa, I know that in DR Congo and Nigeria, a campaign may not be the most appropriate way to stop the outbreak. It should be evidence-based with epidemiology and very targeted intervention that we will be advising. The work is ongoing on the regulatory side in parallel with the EP and the implementation science that we are looking for. So likely the first countries to go for vaccine will be DR Congo that already have a proposal of vaccine. Nigeria also is advancing. With our colleague from Africa CDC, they are also working with us in parallel. Thank you very much.
And Professor Ogoina, would you like to add something on this last question?
Fully agree. Nothing to add to what Dr. Abdullah said.
Thank you very much. Well, with this, we are bringing this press conference following emergency committee meeting to the end. We will send video footage of this press briefing, as well as opening remarks by Dr. Tedros by email, as we always do. And now I will give the floor to Dr. Tedros for his closing remarks.
Yeah, thank you. I would like to thank Professor Ogoina for chairing the emergency committee and also for his presentation and participation in this presser, and through him also to all members of the emergency committee. And I would like to thank the members of the press for joining us today, and see you next time.